So Dr. Solafte joined the University of Alberta in 2012, and he's currently an assistant professor and also the residency program director in the Department of Ophthalmology and Visual Sciences. He received his medical degree from Cauca State University in ophthalmology from, I believe, Baraquer Institute in Bogota, Colombia. And he became a pediatric ophthalmologist and strabismus specialist in 2006 at the University of Toronto. In 2015, he received the International Scholar Award, and in 2016, he received the International Ophthalmologist Education Award, both from the American Academy of Ophthalmology. He's now completing a master's in health professions education through the Netherlands, with an emphasis in educational leadership, in addition to his master's in public health epidemiology, which he received from the U of A here in 2019. And finally, Dr. Solafte has been a volunteer with Orbis International for the past 16 years. Orbis International is a nonprofit organization that brings people together to fight and to help fight and avoid blindness across the world. So again, Dr. Solafte, thanks again for taking the time, and the floor is yours.
Dominic, thank you so much. Can you hear me well? Just want to be sure that you can hear me well.
Yes, we can.
Okay, perfect. Hello, everyone. Thank you so much to Dominic and Patricia for the invitation to participate. I have a big passion for global health, and I have been doing it for I would say for the last 20 years of my life. And I'm going to show you some of the key features, what I find interesting about working in the world. And I have no financial disclosures or interest. I want to say, and I want to declare that I'm currently a volunteer faculty with Orbis International. I used to be a staff in Orbis International. So most of the slides that you're about to see, so the slides that I took over my times with them. So I think we need to start defining what's global health. We need to start. This should be at a starting point. And global health is, as it is described, is the area in achieving equity and health for all people worldwide. Okay, but now here an important word is coming to, which is equity, and that's what we are going to start looking into that. So when we look into global health, okay, we want to improve the health worldwide. We want to reduce the disparities. We want to give protection for problems that transcend national borders. Because now here, it's not only, now we're looking into a bigger picture. Now we're looking into areas of the world, continents. So this is a little bit different than just to help one specific region in one specific country. What I said before is all about equity. And I want to make a big difference here, because you're going to talk about global health, but this is not international health. Global health meaning one helping the other one complementing the other one. But international health is when developed or industrialized countries helping the poor and underdeveloped. That's when we have the missions from Canada, United States, or the European countries going to places like Latin America, Africa, or Asia to do those missions, quote mark, and that's international health. That's not true global health. Disparities are all over the world. That doesn't matter where we are. We're going to see this. We see it locally here. We see the disparities in our country within one place and the other one. But this is a hospital. Actually, this picture is taken within a hospital in India. As you can see, the conditions are very much different than the one a hospital could be right here. So global health has had multiple areas: respiratory, malaria, tuberculosis, HIV, diarrhea, mental health, maternal health, violence, chronic disease, you call it. There are multiple different ways. We are still working. We have tropical diseases which are neglected. For those of you who are in places like Canada, this might not be of your interest because you don't have them. But like me, when I grew up, and I grew up as a doctor in a country with every single possible tropical disease. So for us, that was a bigger issue. Now, HIV, tuberculosis are becoming more important because actually they are resurfacing all over again, not our topic today. So global health isn't always focused on determinants and distribution of health worldwide. And we have to look into here, the global health involves lots of issues. I have a master in public health, but mine is in epidemiology. I'm an epidemiologist. So here in medicine, we're looking and we diagnose and treatment a person, one person. In epidemiology, myself, we look how the disease or the risk affect the population. It's not only the person, but how the disease affects the population, how we can prevent, how we can manage it. Public health studies the health of populations, demography studies the population, and economics looks into how disease affects and find the best cost-effective way to treat it. We cannot work with only one. Global health comprises all of them. So global health will give us a factor in epidemiology, public health, demography, economics, and that's the best way for us to treat and get to control. Blindness is a big issue in the world and very complicated one. Because actually, if we look into the world, taking in consideration that we say we have 8 billion people around that, we just crossed the barrier not long ago, but this is an estimate for a year ago, we say 1.3 billion people, that's 1/8 of the world is blind. That's a big number if we compare against other diseases. So in regards of distance, almost 200 million had mild vision impairment, 270 million moderate to severe vision impairment, and 36 million of the people are blind. Regards to near vision, 826 million people live with a near vision impairment. And we are not accounting for anyone over 40, like me, that we have to use glasses to read. This includes severe and permanent forms of blindness. This is just a two common areas in the world. As you can see, here the corneas are completely gone. And this, in order to restore vision here, will be costly, difficult, and it's better maybe to prevent. So the leading causes of vision impairment are uncorrected refractive errors in cataracts. The situation here is 80% of that vision impairment is avoidable or preventable. And most of the people with vision impairment are over the age of 50 years old. Of course, cataracts is going to be number one, but we still have some other ones also quite complicated. Pediatrics. Pediatric cataracts are complex, are difficult to manage, require significant amount of technology, and unfortunately, quite common. Not as common as in adults, but it's still producing a lot of morbidity and produce long-term sequelae. We also have the refractive errors, the strabismus. We have simple like using glasses. This is one of the pictures that I like the most, and I took this one in Ethiopia, in Addis Ababa. Even for them to get glasses was difficult and complicated. Or when we go to other places of the world, we see glasses become an issue. This is in Myanmar. This is in Mandalay, Myanmar. So, but you can see the difference. Look at how a cataract, this is with the pupil dilated. Look the expression, look the face, look what happens after we have a cataract in the left and a cataract done in the right. That's a big difference. For sure, it's a big difference. Let's go back. Let's look into our house. Stevie Wonder. Everyone knows him. But do you know why he's blind? He's blind because retinopathy of prematurity. He was one of the best premature babies to survive extreme prematurity at the time. And there were no way, they didn't know how to treat it. And this is in the United States. And he is blind out of that. And unfortunately, that is permanent. And now these days, it's avoidable and treatable. Andrea Bocelli, excellent singer, congenital glaucoma. He had a congenital glaucoma in both eyes, and unfortunately, his only seeing eye, who was really complicated, he had an accident playing soccer, and he lost the vision in his only eye when he was 12. And this is another issue. So with all of that is, what can we do to help? because my goal today is try to give you some ideas how you can volunteer, how you can get involved with organizations or even yourself, and how not only for blindness, but for any other situations that you will say, okay, this model may work. This model that they present might be useful for what I want to do. So let's talk about blindness today, but believe me, you can apply this to anything you want to do. There are multiple organizations with different missions. Everyone has different, they want to go to different places. Everyone is under the umbrella of the World Health Organization. And in ophthalmology, all the organizations got together and they created the International Agency for Prevention of Blindness. What they were trying to do is not to have 5 or 6 different leads pointing in different directions without a clear north. So the IAPB is trying to organize and have at least everyone working under the same umbrella. And this actually has been proven to be very effective because we have one of the biggest ones, like a CVM, which is German, Christian Blindness Mission, Sight Savers, Helen Keller International, Lions Club, Rotary Club, SIVA, and Orbis that I represented. And all of them, they also have a Vision 2020 international project. When I joined Orbis, that was the year 2000, and we were looking, Vision 2020 was, oh my goodness, it's 20 years away. Guess what? We're in 2022. We already passed that we did not even get close to our goals. So how do we help? There are different ways to do it. And I want to present to you 4 different ways that you can work. And this is a model, and these are 4 different models that you can follow in order to achieve what your mission and your personal goals are. Number 1 is service. Number 2 is teaching. Number 3 is capacity building. And number 4 is advocacy and policy development. Let's go with the first one, service. What do we do? To provide specialized service when it's not possible or does not exist. This provide high volume of cataract surgeries, advanced retina surgeries, it happens in oncology. It has a great effect, but it's very short in time. It's not sustainable over time, but if you're the provider, you have a great satisfaction because you went to a place, you did 100 surgeries, fantastic. Those are really lucky, fortunate people that were able to get the surgery. But what happened to the thousands of people that is still waiting? So what happened with them? So this is very expensive. Take missions to a country, takes a lot of money, a lot of effort, and yes, successful in some degree, but it's not sustainable. And this is just an example. This was all over CNN. And this is a single doctor, a single person who has done in a country like in Nepal, that has very few ophthalmologists. Dr. Maverick, as they call him, has done already 100,000 cataract surgeries over his career. And it's amazing how he does this. See, this is just the post-op of the following day. This is like a meal. They just go cataract after cataract after cataract, and he has refined his technique so much that this is just the waiting area of the hospital. Just people either, well, most likely you see everyone is in a patch. So this is the post-op the following day. This is just 1 day of cataract surgeries. So I'm sorry, I skipped the video, but he can do a cataract surgery in 2 minutes. It's amazing that he's able to do this cataract in 2 minutes, but indeed he does. And of course, he can do many, many a day. Normally in our setting, a cataract takes about 10 to 15 minutes. So teaching, that's what we do. That's what I do, is pass knowledge and skill to others. Here, we are encouraging learning. But when you're doing teaching, it's like when you're with the students, it has to have dedication and study from the host. We have local advancement of skills. We can have it in any form, online, hands-on, conferences, board, just typical chalkboard, symposiums. These learning activities and learning tasks are multiple, but you need to have and encourage group ready and receptive to take the challenge to do the study. And this one visit doesn't solve all. We have to have long-term plans and definitely curriculum design, objectives, and evaluations. Teaching is something that Orbis does all the time. In nursing, this is me giving a lecture and promoting lectures in China. You can see how the symposium was busy and well attended. But I believe, and this is my personal belief, this is my preference, is to do capacity building. Because the capacity building, you're not only teaching, you're helping the host to build their own resources. Capacity building is defined by the process by which individuals and organizations obtain, improve, and retain the skills, knowledge, tools, equipment, and other resources needed to do their job competently and to a greater capacity. So that's when organizations partner one with others. So this is how we do it. This is one of the most successful stories, and this hospital is Melanic 2 Hospital in Addis Ababa. When Orbis went for the first time, they didn't even have microscope. They didn't. And we're talking about the year 1998. So Orbis partnered with several organizations, and mostly from the United Kingdom, to start providing instruments and start providing microscopes and start providing resources. There are groups that make or they secure funds through donations to get technology or to get the lasers, and this is how that was done. Why I say successful? Because with the years, Melanic 2 was able to do the first cornea transplant in the country in their history. Because actually, finally, they had the training, they had the microscopes. Finally, although this is a little bit of an older model. And ophthalmology has also to adjust. We need to adapt. We need to go to certain places. So for us, yeah, we use the alphabet, but the alphabet changes from place to place. So we also need to understand that what we believe are standards do not apply to other countries. Our standards apply only for Canada. Those North American standards only apply for North America. They don't apply elsewhere. So we need to create the standards for each place. We need to adjust what the host need in each place. So the needs are different. In other places, like in Uganda, like where this picture was taken, cataracts are a big problem. So maybe cataract is a big problem in that place. But if I go to Peru and Latin America, cataracts are not the major issue. The major issue is childhood blindness. Or if I go to Ethiopia and Northern Africa, the problem is not cataracts, the problem is trachoma. Or if I go to India or even China, diabetes becomes another issue with diabetic retinopathy. So everything has to be customized for the different locations. So teaching involves, so capacity building involves working with a local doctor. So we need to take local doctors, like in this picture in Madras in India, and look into how we are going to take them to the next level. We get to them where they are in whatever level they are, and we are moving one level up. We're not pretending to take it all the way up, because this is like a ladder. It has to be done by steps. So we need slowly to go one by one, and it's a process. We need to teach them how to do surgery. We need to supervise. We need to not only teach the surgery, we need to help them to create everything that is happening around that OR. They need to learn how to do the surgery. The nurses need to how to handle the instruments. The anesthesiologists, they need to learn how to do ophthalmic anesthesia. In the biomed, they need to learn how to take good care of the equipment. And a good administrator needs how to manage an efficient ophthalmology OR. And somebody who works in policy needs to learn how to manage policies nationwide. Nursing is really important, man. The biggest problem, and what the reason I have this picture here, the biggest problem that we have is not the donation of equipment. People donate tons of equipment, but after a month, all the equipment is gone. The equipment is not well protected, not well kept. And in ophthalmology, I'm going to make a comparison. One forceps in general surgery is about $3. One forceps in ophthalmology is about $250. That's the difference in a forceps, which is microscopic, compared to a forceps in general surgery. Simple, like how to wash the hands. Simple, how to do pre-op assessment. What is safe? This is me teaching how to do surgery. How are we efficient in the way we move? Teaching also how to manage IT, how to connect to the IT systems, how to manage electronic medical records. All of that is part of capacity building. And the most important, in my opinion, is this one: advocacy and health, advocacy and publicity and policy making. Capacity building doesn't work if there is no good support from government and local officials. It has to be a good buy-in from the country to support a program that is being established. If there is no good support through the national committee, in this case from prevention of blindness, or having a good evaluation for the Ministry of Health, the program is not going to be sustainable over time. And we want to be sure that they understand what is happening. So we used to, at least I participated in many of these policy events where when we were just discussing with the politicians openly about blindness issues. But this can be applied to any disease, any situation that you may think of. Now, I want to talk a little bit about Orbis, and I'm sorry that I'm being biased here, because I work in this plane, and I was the director of this plane. So I want to tell you a little story, because this is an example of how capacity building works. Not necessarily that the Orbis is the only organization who does it. This is done by many organizations, but this is as a model for you to see how it works. Orbis is way bigger than just the plane itself. The plane is like a university. We used to call it flying university, because the plane is a hospital built inside. And out of these 92 countries where Orbis has been since 1982, I had the fortune to be in 57 of those. And we have been working, studying, and working with partners. We have long-term partners in many countries. So Orbis was able to be accredited from the American Association for Accreditation of Ambulatory Surgical Facilities. So, because we wanted to be sure that this is a hospital working with a United States plane, it has to be accredited by United States. And we did it. So, and this is the model that I was talking about. A flying hospital or a project consists on a little bit of everything. We have to work not only in a screening evaluation of patients when we decide to go. We need to train the eye care team. We need to teach them or help them to deliver the eye care service. We want to do, one second, I have something here, public awareness and education, but we have to do advocacy on the inclusion of eye health. All of this has to be part of the project. The planning process has to be well done. I will say in Orbis, we used to prepare visits a year in advance. When we visited the country, we do an assessment in country. We meet with the stakeholders. We meet with the Minister of Health. We meet with all the people who are wanting to participate. This is not just a mission. This is a capacity building. So we need to see what's on the ground, what are the needs. And in paper, everyone, they will tell you that they can do everything, but you need to go and see what in reality they can do. And you start this communication. This is two-way communication until you plan a teaching program or a training program or a skills transfer program. And more importantly, is always has to be a memorandum of understanding where you're going to sign with the country, being absolutely clear whose responsibilities are from the host and the person who is going to deliver. These are just some examples of many of the training programs that we have. And we have local, this is a local physician with an Orbis physician, a local nurse with an Orbis nurses, and anesthesiologist with anesthesiologist, and we partner one-to-one. This is inside the plane, by the way. This is a fully functional hospital inside the plane too. This is me doing the same, but in Philippines. This is in Visayas, near Iloilo, where I was just trying to do some teaching. As you can see, I was partnering with all the local physicians. We were just discussing about how to do extravisional surgery. But at the same time, you can see how the nurses are the one in the dark blue. Those are the nurses who was supervising the local nurses how to do the handling of instruments. The same thing that I was telling you before. Sadly, this is where most of the money gets lost in improper care of instruments, recovery, education in anesthesia, how to do proper pre and post care of patients. And this is me doing a little bit of fun. Yes, we kind of start on the wings of the plane. And at the end, you always have somebody who is happy, who is part of your success. And when you leave the place, you want to know that they are able to succeed. And I want to tell you a story. And perhaps this story is one of the best I have seen in my 20 years of career with international global health. And this, I went to Kunming, China. This is not the picture. This picture is in Myanmar. In Kunming, China, I was able to witness a local doctor and one of our local teachers, and all this. They booked 15 cataract procedures with a specific technique. The first 5 were done by our local volunteer faculty, our Orbis volunteer faculty. The next 5 were done half and half. The last 5 were done by the local Chinese doctor on her own. When I came back to do the post-visit 4 months later, and I went to Kunming, I found that this doctor alone has done over 600 cataract surgeries in that 4-month period of time. So that is a success for me because it took us 15 cataracts that reproduced already to 600 in 4 months. So what's going to happen in 5, 10, or 15 years? So hopefully this doctor will train others and others and others. So that is that's true capacity building. So I have been with many places, and this is in Canadian. This is Entebbe, Uganda, where I was with Dr. Karim Danji on the right. He was the chair here in our department. He has now moved to Aga Khan University in Pakistan. He's a glaucoma specialist. Dr. Gordon Douglas from University of British Columbia doing glaucoma. The tall gentleman in the back is Dr. Peter Dolman, oculoplastics from University of British Columbia. And the gentleman in the back, without a jacket and in a white shirt, is John Anderson from Harvard, is one of the anesthesiologists. Yes, and believe me, they treat you well. This is one of my favorite cities where I have been. This is Aleppo, Syria, back in 2008, with the most amazing food you can even imagine. It's sad to see what happened to that country. One of my favorite ones in Syria. This is Myanmar. They wanted to treat you well. It's not as fancy, but believe me, it was equally as good. And my last, just to finish, and I want to finish in the next 5 minutes, we have time to discuss. This is Cameroon. This is Yaoundé, Cameroon. I saw this kid in basic strabismus. I was teaching some local doctors. You saw one of the pictures. And I did the surgery for him. And his dad which is here showing at the very next day of surgery, asked me, Dr. Solarte, where are you from? And I say, I'm from Colombia. Says, oh, thank you so much. This is on the day of the surgery. 2 days later, when he came from post-op, the shirt that the dad is using is the Colombia soccer team shirt. Actually, that's the official soccer team, the shirt that they play. They play in national and the matches. That was his way to say thank you. I found that this was absolutely outstanding. That somebody in Yaoundé, Cameroon, is going to go to the streets to find the Colombian national shirt just to wear on the day that I was going to see his son as a way to say thank you. I think that was one of the best, and I would say, most emotional moments I have had in my career. And thank you so much. And this is all. And I'm very, very happy to discuss or answer questions. I hope that I stay within the time frame.
I can start maybe, Dr. Solarte. The effect of COVID, I guess, on organizations like Orbis, I assume many of the operations and projects were put on hold and hopefully restarting.
Yes, Dominic, that has been incredibly harmful on any organization, specifically for organizations who have projects on the ground. Many organizations, I'll talk about ophthalmology. The IAPB, the International Agency for Prevention of Blindness, they have projects all over the world, and all those projects came to a halt. Everything came on a standstill for two reasons. Number one is because on the operational side, many countries had restrictions. Nothing could move anymore. There was no transportation. No cargo was very difficult to get from point A to point B. Number two, all these organizations live out of donations and the goodwill of and the good heart of people, mostly in industrialized countries. So it's difficult to get the funds to continue running these long-term projects. Specifically, when you're doing capacity building, those projects are multi-year projects. They don't happen in months. That has been really difficult and complicated. So now, year 2023, almost 3 years after we went into lockdowns, the country, most of the projects are starting to happen now. Most of the projects are starting to work again. At least we have some green light from places to restart some of the work, specifically not the international portions, but in-country portions. Like and Zoom is our good ally right now. We do a lot through Zoom now, but it's not the same like to be in surgery. You cannot teach through Zoom. It has to be one-to-one. We can do a lecture over Zoom, but we cannot teach surgery over Zoom.
Okay, great. Thank you. So a couple of questions in the Q&A box here. I can read them out loud. First one is from Mahad. He says, I once heard from an indigenous leader that they had an elder who was capable of removing cataracts with an obsidian blade by hand. Is this possible?
Yes, it is. And it's a century-old tradition, specific in Western Africa. They call it couching. And actually, it's dramatic to witness it. I only have seen it in videos because it's quite impressive. They just go with a really, really tiny sharp object. It's almost like an intravitreal with an injection, and they just hit the lens to a point that they luxate the lens so it gets out of the visual axis. That's all they do. But the risk of endophthalmitis, infections, retinal detachments, all of that are incredibly high. But they used to do it, and now I don't know they still doing it in some places in Nigeria or Ghana. I think they still do it, maybe in the farthest communities. But yes, it still exists.
Very interesting. The second question from Kim, is there an upcoming Orbis project that the Edmonton team is participating in? If so, where's the next location?
No, Kim, we don't have yet that. My personal project has been Mongolia. Ulaanbaatar in Mongolia. I'm since 2019, or sorry, 18. I have not in the plane anymore. I am helping to build the pediatric ophthalmology training program in Ulaanbaatar in Mongolia. I went to Mongolia 3 or 4 times before COVID. We're hoping to go back sometime late 2023 or early 2024 because Asia is still a little bit closed with COVID. And unfortunately, we'll have to transit through China to get to Mongolia. There are very limited flights. So that is still a little bit on hold, but we're still working online. The plane is right now is moving to India. And the plane is going to start in India, but not that we are related ourselves just yet.
Okay, one more question here from a participant. What can early learners, such as med students, junior residents, do to get involved in global health initiatives, specifically in ophthalmology?
Oh, many. But it depends which organization you want, the student you want to work for. There are many. SIVA, Lion Club, Orbis, Rotary Club. They all have local chapters. They do international work. And it's just to find the organization that you feel more comfortable to work with, that your own principles align with them. And that organization, but you always need to be under the umbrella of a group. This actually is the easiest way to participate and the most organized and accepted in a host country.
Okay,
I
great.
think that we have a question from Dr.
Yes,
Houston.
Dr. Houston has a question. Go ahead, Stan.
Hola, Carlos. Que buena verte.
Hola. Muchas gracias.
So, yeah, that's great chance to a great presentation to emphasize the importance. I mean, visual loss, of course, is a devastating problem anywhere, but it's even more devastating in a low-income country setting where there are so few resources to compensate, and where you need to be able to see where you're going to do just about anything, and even to survive. So 2 questions, if I could be allowed. First of all, for some important eye diseases, the key preventive interventions are very basic public health, and so maybe that's not what Orbis does, but so I'm talking about vitamin A supplementation, trachoma control, and of course the onchocerciasis control programs, especially in West Africa. Is that in the scope of Orbis or
Yes, Stan, yes, it has been for many years. Specifically, Orbis has an operative office in Ethiopia, and the Ethiopia country office has been always working in the ground in the lower lands of Ethiopia and neighboring countries with helping supply the water, helping supply the eyelid care. And even they partner with other groups in Pfizer for the azithromycin plan. And in the management of trachoma, since there are no ophthalmologists, there were some nurses who they were trained to do very basic procedures to avoid the blindness due to trachoma. So this has been, I will say, from 2007, 2008, about that time.
Okay, my other question is follows that a little bit. So in many areas we talk about the concept of task shifting. So do you need to be a doctor to do a modern trachoma surgery? I'm not talking about the coaching procedure.
No, and actually, in one of the models that was used in Uganda and Kenya and Ethiopia is to do training certain specific nurses which are quite basic training. They were taught how to do basic eyelid surgeries, how to manage the entropion or ectropion following the trachoma. or even to manage very basic trichiasis. Because it's not all, sometimes not only give the antibiotic where it's important, it's also how to prevent that the eyelashes do not rub against the cornea. And that, because it was not possible to have ophthalmologists in those areas. And they were trained how to do it. They did it successfully. And there are centers that are only managed by paramedical personnel.
And cataracts?
No, not in cataracts. Not in cataracts, no. Cataracts requires a little bit more training. And now the deal was, in these cases, was to emphasize better, more training and more numbers of residents going through training. Because actually cataract is still, a cataract when it's successful, fantastic. But a cataract goes wrong, it can be really devastating. It's people do not see it because cataracts is the level of complications with a trained surgeon is not as high. But when the cataract goes wrong, it goes really downhill. So, that's the other side.
Okay. Super. Thanks, Carlos.
Oh, no problem, Stan. Very nice talk to you.
Thank you. We can go back to the Q&A, and there's another question. Have you ever worked in an active war zone, and what are the challenges that come with it?
Not exactly war zone. We have to evacuate once from Ethiopia. There were very severe riots in Ethiopia, and we were asked to leave the country. They gave us 2 hours to be at the airport, just enough time to prepare our plane and left, and find any runway nearby to land the plane within 2 hours. We only have fuel for 2 hours. So we went to Nairobi in Kenya. Yes, we did that. I have not been in Orbis, of course, and internationally, they don't allow you to go to places which are considered in safety. When I went to Cameroon in Nigeria, I went to Ilorin, Nigeria. We could not go out of the hotel, and we have armed guards around us all the time, and we could not go. Even for us to move to the hospital, we will have escort armed back in front of the cars, and apparently the area was very complicated at the time. Of course, we're not doing teaching or capacity building in an area which is as an active problems. One of the reasons why we are not going back to, or at least is no plans to go back anytime soon to Syria. We have major projects in Syria, all of them were canceled, and no idea when they are going to be back.
Okay, thank you. And one more question here in the Q&A. How do teams such as Orbis find and recruit physicians from these countries in need? And are their projects only carried out in urban international centers, or are there rural missions and trips as well?
Okay, that is a really good question. So the question here is we have to look, where are we going? Okay, what are the goals of the place where we are going? Orbis has a people in the ground who works the logistics, who works the admin side, and make things happen. They partner with local, once the country is selected or the place is selected for the project, and Orbis Advanced Team, which is multinational, Orbis Advanced Team has representatives from ideally all over the world, and they have people who speak pretty much, I would say, many of the most common languages. Will go to these locations, and they do and they look and say, what are the needs? Okay, the needs, we need a cataract surgeon who knows how to do without phacoemulsification. Phaco is our way to go, but it's very technological. So maybe it's not effective in other places in the world. So we need somebody who knows how to do it. North America is not the place to find that person, because in North America, we use phacoemulsification for everything. Our own staff don't know how to do it another way. So we need to partner with places to know, and that's India. India is the #1 in the world where they do non-phacoemulsification cataract surgery, and they go to places like Arabind or Shankara Netralaya in Madras, which these are fantastic surgeons, and they become volunteers, and they now go and teach. This is very customized to the needs of the place. Now, Orbis tries always to be multicultural, multi-represented, to have people from all over the world. Because this is not only, although the organization is based in the United States, it's not only United States of America trying to teach other people. This has to be, remember, it's global health, one helping others, not in international health, one place working in underserved. This has to be back and forth, and everyone has to help.
Great. I think that answers that question. Any other questions for Dr. Solarte or comments? And just FYI, I see Patricia's posted our links for our next round on January 10th. Thanks, Patricia. Okay, well, if there's no more questions, I'd like to thank again Dr. Solarte for taking time to be with the group today and share your experiences, your knowledge, and some background on the work that Orbis is doing. Really appreciate it. This is our last rounds before the holiday break, so I'd like to wish my Merry Christmas, Happy New Year to everyone. Hopefully you have some time to rest a little bit and time with your friends and family as well, and especially Dr. Solarte, that you get a little bit of time off.
Perfect. Dominic, to all the group, thank you so much for coming and listening to a little bit of global health. I hope that this is an exciting area. I hope I was able to spark your interest. Merry Christmas to all.